Welcome. I'm so glad you could join us today. My name is Aline Sigler. I'm with Provider Outreach and Education. Also on the line with me is Karen Curtis. She's serving as my co-host today. I want to thank her for her help behind the scenes. She's going to be monitoring the chat, adding some links and other details into the chat for me today. Something that I can't see when I'm sharing my screen in full mode here. Today's session is part of a series on skilled nursing facility billing. We also have a series focusing on SNF consolidated billing. SNF is what we call skilled nursing facilities. Medicare's full of acronyms, and that's just one of them. Live webinars are also held periodically throughout the year on consolidated billing. We also have encores and other videos on our YouTube channel. We have a couple different playlists for you. One dedicated to skilled nursing facilities and one for skilled nursing facility consolidated billing. These sessions are designed as entry-level courses. So for those of you that are just beginning to learn about Medicare, coverage of skilled care, and what that all means, today we're looking at some of the unique situations that you might encounter that impact your normal billing of claims. We're going to begin with benefits exhaust, and then we'll talk about no pay billing, encounter claims, and finish up with a little bit about leave of absence, same day transfer, and demand bills. So we want to start with just a brief recap of some of the definitions and coverage criteria for those who may have missed our prior sessions or might be watching our encore presentations in a different order. So as we define a couple key terms here, first up is skilled services. For Medicare purposes, skilled care is nursing or other rehabilitative services. They're going to be provided according to a physician's orders. So a physician is going to order and certify a patient's need for skilled care. A skilled service requires the skills of qualified technical or professional health personnel. So this is going to be people like registered nurses, licensed practical nurses, physical therapists, occupational therapists, audiologists, or speech language pathologists. So not just an aide or an assistant, but these are things that are within the scope of a skilled professional. Medicare considers a service skilled if, because of its complexity, it can only safely and effectively be performed by or under the general supervision of skilled nursing or skilled rehabilitation personnel. Next, we want to review some of the other coverage criteria for skilled care. In order to qualify, the criteria here must be met. First one is the 3-day prior hospitalization or qualifying hospital stay. The patient has to have a medically necessary stay of at least 3 consecutive calendar days. Now, this could be at one or more hospitals as long as they are 3 calendar days in a row. To be covered, the extended care or the skilled stay has to have been for treatment of a condition for which the beneficiary was receiving those inpatient hospital services, or a condition that arose while in the skilled nursing facility or swing bed for treatment of the condition that made the hospital stay necessary. So they have to be connected somehow. The hospital stay that qualifies the patient for Medicare also has to have occurred within 30 days of the skilled admission. We call that the 30-day transfer rule. There's a medical appropriateness exception, which could make it acceptable for more than 30 days between hospital discharge and the beginning of skilled care. If the patient's condition makes it medically inappropriate to begin skilled treatment immediately following their hospital discharge, but it is predicted that the skilled care will be needed within a predetermined time frame. Some of those situations may be 2 weeks, 4 to 6 weeks. There's maybe a time of healing that has to happen before the patient can begin, just as an example, skilled rehabilitation. We determine that a skilled service is one that can only safely and effectively be performed by or under general supervision of skilled personnel. Another criteria for Medicare coverage is that the patient needs that skilled nursing or skilled rehab on a daily basis. Many of your residents might require both. They might need skilled nursing and skilled rehab. And then the last bullet here on this slide is that the patient has to have skilled days left in their benefit period. What do I mean by benefit period? So that's the next thing that we're going to define. A benefit period is the way that Medicare measures coverage for Part A claims. There's a specific number of days for inpatient hospital care and skilled nursing care. A benefit period begins the day a patient is admitted to a hospital or a skilled nursing facility as an inpatient. And then it ends after a period of 60 consecutive days where the patient is either facility free, meaning they're not an inpatient at any facility, or they're in a skilled nursing facility or a swing bed stay, but at a non-skilled level of care for 60 consecutive days. A patient can have multiple benefit periods in a single calendar year, or they could have one long benefit period that lasts several years. But that 60 consecutive days is very important in keeping track of the patient's benefit periods. For skilled nursing facilities or swing beds, which swing beds are a bed in a hospital for skilled care, and we talked about that in one of our earlier sessions, and if you want to check that out, again, you can find it on our YouTube channel. Each benefit period for Medicare for skilled services has 100 days. Medicare covers the first 20 days in full after the Part A deductible is met. And then after those first 20 days, days 21 through 100 have a daily coinsurance amount that the patient or the patient's secondary insurance is going to be responsible for. Most patients have a Medicare supplement that will pick that amount up. So next we're going to talk about how often skilled nursing facilities or swing beds have to bill. Skilled nursing facilities and swing bed claims are billed monthly. They do have to be billed in sequential order. And then you're also going to bill when any of the situations that you see here occur. When the patient discharges, if they drop to a non-skilled level of care, when they have no more days left in their benefit period, so they've used all 100 days, or if they're enrolled in a Medicare Advantage plan, we require a claim to track the days, and we'll talk a little bit more about that later. So as we transition into some of the less common billing situations, we want to note that there might be some of these that you've never heard of before. You've never encountered them. We have all different levels of experience on this webinar. And so we just want to recognize that if you don't understand or you've never heard of some of these things, don't feel bad. Keep this information where when you do come on that situation or you have a beneficiary who meets one of these criteria, it'll help bring it all together and full circle kind of for you here. So they might be unfamiliar to you now, but as you continue on and you learn more, then it will make sense to you. So the first one that we want to talk about is benefits exhaust. So we just defined what a benefit period is, when it begins, when it ends. So this kind of seemed like a natural segue into this topic to talk about what happens when a patient uses those 100 days and they're still in your facility. You're required to submit a bill, even if no benefits are payable by Medicare. And that might seem confusing. If they don't have Medicare benefits for this stay, why would I go to the time and the trouble to complete a bill? Well, the easy answer is because CMS says so, but CMS has a record of all inpatient services for every beneficiary. In the claim, this enables them to keep track of that beneficiary's benefit period. You have to submit a benefits exhaust claim every month for those patients who continue to receive skilled care. So those types of services that only a skilled professional can provide. And when there's a change in their level of care. So regardless of if its benefits exhaust claim is going to be paid by a private insurance company, a supplemental insurance company, or even Medicaid, we still require that bill to be sent. There are two types of benefits exhaust claims, and they're just exactly what they sound like. See them defined here. Fully exhaust means that there are absolutely no days left to cover any of the days on your claim for this month. Partially exhaust means at least one day of the claim has a benefit day available. The status of the patient in regard to the number of days left is going to make a difference in how it's reported on the claim. So as we move into talking about a couple of those different scenarios, this will all make sense to you. So certified beds refers to the beds within a facility that are designated and eligible for Medicare reimbursement, not just any bed in the facility. Some facilities have 100% of their beds certified as Medicare beds, and some facilities only have a certain number of them. If you're not sure about your facility, you can check with someone in your billing office or your administrator. They'd be able to tell you, are all of our beds Medicare? Are they dually certified for Medicare and Medicaid? Do we have some beds that are only Medicaid? How is that within your facility? Because it really could be different for each person on this call today. So here we have the billing instructions for billing benefits exhaust claims when the patient moves to a non-certified area or bed. You're going to bill with a covered type of bill. In our last installment of this series, we talked about the different bill types and some of the common ones that we use, but it's going to be a payable bill type. You're going to use the default HIPS code, and HIPS stands for Health Insurance Prospective Payment System. You're going to use that default code of ZZZZZ if there was no assessment. If you're a critical access hospital swing bed, this might seem like a foreign language to you, and that's because it doesn't apply to you because you are not paid under the skilled nursing facility prospective payment system. And we have a variety of people on this call. So we have swing beds and we have freestanding skilled nursing facilities. You need to make sure that the 70 span code for that qualifying hospital stay, those dates, is present on the claim, or it's going to reject or return to you with a denial stating that the qualifying hospital stay is not there and not for benefits exhaust, which is what you're going to be looking for in this situation. Because if you don't code the claim correctly, you're not going to get the correct message on the finalized remittance advice that you're looking for. In this situation, you're going to bill all the days and the charges as covered, as if the patient had days available. And I know this sounds confusing, kind of contradictory, but let me explain that just a second here. So this is so the system can verify the benefit period when the claim is transmitted to the common working file. The common working file is the patient's master record with Social Security, and it tracks all inpatient stays. So it needs to follow that patient from the inpatient hospital stay to the swing bed or the skilled nursing facility, you know, maybe back and forth, depending on how sick the patient is or what they have going on. So it needs to connect all those dots to get a full picture of that patient's stay and benefit period with Medicare. So you're going to bill all your days and charges as covered. Likewise, for the coinsurance value code, instead of trying to calculate the amount that the patient may be responsible for, CMS tells providers to put $1 in there and let the system calculate it. If the claim is partially exhaust, it's also at that point then that the system might add the A3, A is in Apple, 3 occurrence code, and a benefits exhaust date. You might see this on claims and wonder how it got there, because if you're the biller and you didn't put it there, it's something that the system assigns. So you would never have to add that yourself. And then the last thing to mention in this scenario is the appropriate discharge status code, the patient status code. At the end of this month or this billing cycle, what's the status of the patient? Are they still a patient? Are they discharging to another facility? Are they discharging to home? Are they transferring somewhere? What is that patient status code? We need that to be correct for your patient's situation. Our next scenario is those patients who drop to a non-skilled level of care while benefits exhaust, but this time the patient is discharged from the facility or going to a non-certified bed. Oh, did I skip a slide? Let me start that over again. If the patient drops to a non-skilled level of care while benefits exhaust and remains in a Medicare certified bed, this slide outlines those billing requirements. I apologize, I got moved ahead in my notes here. So many are the same situation as our previous slide. Covered type of bill, the occurrence code 70, $1 with the value code for the coinsurance, patient status of 30. This time we need to notify the system that the patient is moving from a skilled level of care to a non-skilled level of care. So maybe they no longer are benefiting from rehabilitation. They're going to be what we call a long-term care or custodial patient now. They can't go home, but they don't have a daily need for skilled care. And so that's what would be a triggering event to let the system know that this patient is still here, they're still in a Medicare certified bed, but they don't meet the criteria for skilled care. So that occurrence code 22 with the last skilled day is going to be really important, because that's what's going to tell the patient's master record, that master record at common working file that we talked about. That's what starts that 60-day clock for the benefit period. Because if a patient is non-skilled for 60 consecutive days, and then they go back out to the hospital and they have another 3-day qualifying stay, they could start a new benefit period. So I can't stress enough how the accuracy of that occurrence code 22 with that last skill date is how important it is. If the patient receives other services that are billable on an inpatient Part B type of bill, that would be your 1-2X or your 2-2X type of bill, things like therapy and things like that, what you're going to want to do is wait until the Part A claim processes before you send your inpatient Part B claim, to avoid those claims getting hung up or bouncing against each other in the system. So this next scenario then are those patients who drop to a non-skilled level of care while benefits exhaust, but this time the patient is discharged from the facility or going to a non-certified bed or area. You're still going to use your covered type of bill, covered charges, value code for the coinsurance with $1. This time your patient status code is going to be something other than a 30 because they're either leaving the Medicare bed or area or the facility altogether. This time the patient is moving to a non-skilled bed, room, or area. Any Part B services are going to be sent on a 2-3X type of bill for skilled nursing facilities. You should still let that 2-1X Part A inpatient claim process first. Same thing. It's going to avoid the claims bumping into each other or being returned to you for correction. They need to be billed in sequential order. So as we move on then, and we're going to talk about what we call no-pay billing. When other situations occur, Medicare requires you to continue to send a claim even when you're not expecting payment. So just some details about the situations that we're going to talk about here. They're listed on this slide. Patients in a skilled stay, but then drops to what Medicare considers a non-skilled level of care and remains in a Medicare certified bed. If you need a denial notice for another insurance, what you're going to do is send the initial no pay claim with a from date, the day that SNF care ended. This claim follows the one that we just talked about a few slides back when you reported that 22 occurrence code and the last skilled day. Unlike the claim that had a covered type of bill, now you're going to be using a bill type that ends in a 0 because this entire claim is going to be a no pay claim, a non-skilled claim. All days and charges are going to be non-covered, and you're going to use a 21 condition code. You're going to put the appropriate patient status code, depending on if they're still a patient, discharging, or whatever. You're going to add revenue code 0022 with that default HIPS code with the 5 Z's. You'll send the no pay claims monthly. As long as all required elements are present, the claim should process quickly for that denial so that you can send it off either automatically or manually to that secondary or other insurance. If a denial notice for another insurance is not needed, you can send one final discharge claim. And it can be many months all together, and it doesn't need to be split at the fiscal year, either yours or Medicare's. The coding is mostly the same as our previous scenario. No pay type of bill, 21 condition code, default HIPS code, all days and charges non-covered. The from date is going to be the first day of non-skilled care. And the through date then will be the date of death or discharge, whichever the case is. This is also going to tell us what patient status to use depending on where the patient went. 02 for home, 20 if the patient passed away. Those are just some examples. So what other situations do we have here that you might come across? And one of them is a shadow claim. A lot of you listening today might have patients who have enrolled in Medicare Advantage plans. Now, I'm with traditional Medicare, and we require hospitals and skilled nursing facilities to submit what we call informational only claims to Medicare, so the common working file can keep track of the patient's benefit period. And I use the title of this slide as shadow claims in quotations because it's not an official CMS term, but you might hear it called that. So I encounter claims, shadow claims, informational only claims. Just some of the things that you might hear it called. So basically, what you're going to do is make the claim look just like a payable claim. Covered type of bill, days, charges, etc. But you're going to add a 04 condition code. So that lets the system know that this is informational only and apply the days to the utilization on common working file. Some providers accidentally use a 210 or a 180 type of bill with days and charges non-covered. But what that does is it's just going to stall the claim, and it's not going to give you the denial message you were expecting. You're looking for patient is a member of a managed care plan or something like that. But if you bill everything non-covered without the 04, you're going to get kind of a generic denial code that says provider billed non-covered services or something like that. So you're going to be getting payment for the bill from the Medicare Advantage plan. So it's not double billing. Medicare requires the informational only claims, and those requirements are outlined in the Medicare Claims Processing Manual, which is publication 100-04, Chapter 6, Section 90.2. A little further on in our PowerPoint, we have a resources slide, and there is a link to that manual and chapter if you want to go out and take a look at it. And you can see where CMS tells providers that they have to do that. So I hope that helped you understand more about encounter claims and the reasons why we need them. We have a couple other things for you today. Sometimes a patient leaves the facility and isn't back by midnight. They haven't been formally discharged, but we can't count the day or days as covered because of the Medicare regulations. The reasons for a leave of absence can be personal. So they leave the facility to go to a family reunion out of town, go to a wedding, attend a funeral. They go home for the holidays, that sort of thing. A leave can also be therapeutic. So they go to the emergency room. They expect to come back, but they're there past midnight. They might even go home overnight as part of their therapy plan of care to see how well they're able to maneuver stairs or carpet with their new walker or something like that, in anticipation of returning back home. So depending on what the situation is, there's special coding that signifies the reason for the non-covered days as the patient being on what we call a leave of absence. You're going to use a revenue code of a 18X with 0 for the room and board charges. And then the units are going to be the number of days that they were out of your facility. You're also going to use the occurrence span code of 74. So that's going to be a from and through date. That's going to encompass those non-covered days. And it'll allow claims with outpatient charges from other providers during that time to process, depending on the situation, of course. If the patient subsequently gets admitted, so let's say they went to the emergency room, you thought they were just going there to get stabilized or get care and come back to you, but they're not back by midnight. In those cases where they get admitted, that's going to force a discharge from your skilled nursing facility or swing bed stay. So then your billing is going to become a discharge rather than a leave of absence. On occasion, patient gets admitted to skilled care with every expectation that they're going to be there overnight for a continued stay, but a situation arises where the patient has to be transferred to another facility before midnight of that first day. If the other provider participates in the Medicare program, this is called a same-day transfer, and you'll follow the guidelines listed here. Your admit date, from date, and through date are all going to be the same. Your type of bill is going to be, depending on your facility type, is going to be a 211 or a 181. The day will be non-covered, so we're not charging utilization for that day. But any charges that the patient incurred before they left will be in the covered column. Your claim's also going to need a condition code 40. Now, it's true that Medicare can't pay an inpatient day to two different facilities. So no facility gets paid on the date of discharge. So this is kind of a special situation with unique billing requirements. Again, so Common Working File can track the patient's stays, connect those dots, and get the full picture of that patient's benefit period. Now, the last billing scenario that we have for you today are demand bills. So in this instance, the facility determines that a patient no longer meets the Medicare skilled care criteria. They're not able to participate in therapy, or they've gotten better, or they've gotten worse where it's now considered custodial or long-term care. The patient or their representative then has to be given a notice to inform them that Medicare will not, or most likely will not, pay for the services, gives them a specific date and a reason why. And so this allows the beneficiary to make an informed choice regarding their care. If the patient, again, or their representative, disagrees with the facility's determination, then what they can do is mark a box on that form and ask Medicare to make a decision, review their case, and decide if they concur with the facility that skilled care is ending. There's a condition code, and it's a 20. A 20 condition code is what alerts the system that the patient disagrees with the facility's decision and then demands, by way of marking that notice of non-coverage, that they want Medicare to be billed and make a determination. CMS requires 100% of all demand bills to be medically reviewed. So you're going to begin preparing your documentation to support your decision because we will be asking for it. A demand bill is going to be submitted totally non-covered with a bill type ending in a 0. So you may have to split the month into what you believe is the covered portion, utilizing that 22 occurrence code with that last skilled day, And then the rest of the month, that is the demand bill. So I hope that looking at those different billing situations have given you a better understanding of the types of things that you might come across when you're doing billing or you're preparing claims for your facility or talking with patients in a skilled nursing facility or a swing bed stay, depending on what your role is, and give you some idea of how to handle those situations when they do occur. So this slide then contains some resources for skilled nursing facility and swing bed providers. If you downloaded a copy of the slide deck, you have these links. They are live links. If you're listening to this course as an encore, look in the description of the video because we'll have these same links there for you. That way you can go out and get more information. You can see where it is in writing that you have to do things a certain way or why you have to do things the way that we've explained to you. So we're going to go down the list here. 100-02 is the Medicare Benefit Policy Manual, and that's the first one here. And Chapter 8 is where you're going to find the coverage criteria. So the regulations about the qualifying hospital stay, the 30-day transfer, and so on. So I'm going to take you out there real quick. It might take just a second for the system to open that up and do its security checks. So in this manual section here, you can see those requirements. The requirements for the 3-day prior hospitalization, that 30-day transfer that we briefly mentioned, definition of a skilled service, things like that. The next one that I have for you, it's still an internet-only manual, but it's the Medicare Claims Processing Manual. So that's 100-04. And then Chapter 6 is the one that contains the guidance for submitting bills in sequential order, those types of things. So let's take a look at that real quick. It's going to look very similar. Benefit Policy Manuals, Coverage Criteria, Claims Processing Manual is how to bill it. So a lot of those different things that we just talked about. Submitting the bills in sequence. Talking about ending a benefit period. A lot of those things that we talked about. But I wanted to take you back to the regulations where you can see it in black and white to know that you can tie it all together. And where does it say I have to do it that way? Or where does it say that I cannot do that? Now, the next resource that we have listed for you is on the CMS website, and it is the Skilled Nursing Facility Center. This is going to be your go-to for important messages. It's going to take you to and give you links to a lot of other information too. Whether it's skilled nursing facility billing, whether it is consolidated billing, there's links to those manuals that we just looked at. So this can be your jumping off point to a lot of different information. And then the last two references that I have for you here, or resources, excuse me. First one is, a Medicare Learning Network billing reference for skilled nursing facilities. But this does pertain to swing bed too, because a lot of the coverage criteria for swing beds in a hospital are exactly the same because it's skilled care. So this one is the SNF Billing Educational Tool. You might find this helpful for some of the situations that we talked about, and it's interactive, meaning you can jump to different places within this tool. So talking about skilled nursing facility stays, what is a skilled service? What are the coverage requirements? The billing requirements? What do I need to put on my UBO for? all of those different things. And then it also has different sections that expand for some of those unique billing situations that we talked about today. No pay claims, benefits exhaust. So another good resource for you. This is something you might consider bookmarking. I wouldn't print it just because of the way that it is formatted, but if you bookmark to it, you'll always be able to jump to it. And then the last one that I have for you here that you might find helpful is a fact sheet about the 3-day rule. It's another Medicare Learning Network article that you can use to find out more about that. So I hope those will be helpful for you. So now's the part of the presentation where we're going to go over questions and answers. And before I check in with Karen to see what questions you have for me today, I want to address those that were submitted during the registration process. So if you remember, there was a question on that registration form and it said, what one question are you hoping to have answered during this webinar, or something to that effect? First one that I got is, can a resident that's on Part A services bill while palliative care is also seeing the resident? And the answer to this is yes. A resident in a Medicare Part A skilled nursing facility or swing bed stay can receive palliative care. Palliative care is focused on symptom management. It's not the same as hospice, and it can be provided while residents in a Part A stay. And the skilled nursing facility covers these services under consolidated billing. Next question. Is a notice required when a resident comes off skilled services? And we talked about this. Yes, a notice of non-coverage must be delivered to the Medicare beneficiary at least 2 calendar days before you think their covered services are scheduled to end, and that is a requirement. Next question, how to bill type 121 correctly? This is an inpatient Part B type of bill for a hospital. So this question may be in regards to swing billing, and that's fine, swing bed billing. My advice is always to wait for the Part A claim to finish processing before sending the Part B claim. Whether it is benefits exhaust or it is no pay billing, whatever that situation is, let that 211 or 181 claim finish processing before sending that inpatient Part B claim. Next question. Is monthly billing required for benefits exhaust / no pay claims? We did also talk about this in our presentation, but yes, monthly billing is required for Medicare skilled benefits exhaust claims to track the beneficiary's benefit periods. Similarly, no pay claims for residents who remain in a certified bed after skilled care ends are required monthly to prevent billing overlaps unless a denial for another insurance is not needed. And then one last question, when are no pay claims required? And that's the same answer as the previous one. So that was all the pre-submitted questions we have. Now I want to see what we have in chat today. I can't see the chat while I'm presenting the slideshow, and so I'm going to touch base with Karen here and ask if we have any questions in the chat. Karen?
Yeah, thanks for all that great information, Aline. We have had a couple questions come in through the chat. The first question you got is, if we are a critical access hospital, do we need to have the occurrence span code 70 listed on our swing claims?
Thanks for that question. And yes, you do. You do have to follow that same coverage criteria as a freestanding skilled nursing facility. So we need to, and it doesn't have to be in your hospital. It doesn't have to be the same hospital that the swing bed claim is in, but they still have to have those 3 consecutive days as an inpatient related to the care they're receiving in the swing bed and all of those things that we went over. That was a great question. Thank you.
Okay, and the last question that we got is, if a patient admits as Medicaid and has not utilized Medicare benefits, but is in a duly certified bed, are no pay claims required?
That's another good question. If they come in as Medicaid only, then no, you would not. No pay claims are required when they're skilled and then they're non-skilled. So there's a change in status from skilled to non-skilled. If they came in, if they didn't come in as Medicare off the bat, then no, they wouldn't. They wouldn't need those no pay claims. I hope that makes sense.
Okay, great. And that was all the questions that you got.
All right, thank you so much. Thanks to everybody who sent those pre-submitted questions, and thanks to you, those of you that put them in chat as well. Moving on, I do have some important information for you, so I hope you'll stick with us till the end here. The first thing is, and I mentioned this at the beginning, please take a few minutes to complete a survey about this course. Tell us what you liked, what we could do better, and if you have suggestions for future topics, let us know those as well. You have a few options on how you want to take that survey, depending on what your preferences are. Karen's going to place a link in the chat, or when you leave the webinar, you're going to get I don't really want to call it a pop-up, but a screen's going to come up, and it's going to ask you to go to an external site. The message is going to look similar to this box here. It's going to have a triangle and a continue button. And I just want you to know, if that's the first time you've ever seen that, that it is safe. It simply wants to take you to the CMS Qualtrics page for the survey. So it is there. If you're listening to this course as an encore, there's a box that's going to appear that's also going to link you to the survey, but it's going to look like this bottom box here with the hand and the stars. And again, that's going to be your segue into that survey there. However you choose to do that, you only have to do it once, but please give us your honest and open feedback. If you feel comfortable, add your contact information. So if there's something, details regarding your feedback that we can get from you, if you feel comfortable giving us your contact information, we'd love to be able to reach out to you and discuss that. Those surveys not only give us insight into how we're doing, but the types of education that you are interested in, that you want, that you need. Within the next 10 minutes or so, you're going to receive an email, and it's going to thank you for attending. But it's also going to give you a link to the survey. So that's another way. We give you a lot of different doorways into that survey. But I don't want you to overlook that email or delete that email without reading it, because it also contains your certificate of achievement. So if you are interested in contact hours and submitting them for CEUs, that email is what you need. If you don't see it, check your junk or your spam folder. Again, it should be coming in the next 10 minutes or so. Make sure the WebEx email address is added to your safe sender list as well. That will help. If you think of a question later, you do have 1 week from today's live event to submit a follow-up question. You can send them to our same education mailbox, put today's date and something about SNF and swing bed billing in your subject line so that the person at that mailbox knows to send them to me. They'll send them to me, and then I can respond. On behalf of myself, Karen, all of us in Provider Outreach and Education, I want to thank you for joining us today to learn more about skilled nursing and swing bed billing. We hope to have you join us for future events. check out those YouTube playlists if you want to find out about some of those earlier educational events that we did. We look forward to your survey feedback also. So you can now disconnect and enjoy the rest of your day. Thank you, everyone.